So as I said, I've been involved in the various different cycles of learning at Community Renewal, and I created the concept of lifting neighbourhoods together about 7 years ago. It's taken us a long time to actually get it operational, but it's great to be here and talking about something that's actually happening, because we've been talking about it for a long time. As I said, the demo that we did yesterday, we were working that way informally right at the beginning. So from when we started at Community Renewal, we tended to work in a very holistic way. We weren't really specialists in anything, although we were starting from the point of view of trying to support people into employment. We didn't employ employment specialists. We employed people who were good communicators, and they were good community builders. In fact, for the first few years, we called them community animators. That's what their job title was, and they were out knocking on doors and doing the community work. So we were doing that kind of quite informally for a few years. And in 2006, we started to look a little bit more formally at what sort of role would you need to work between the different silos and work between the different sort of public agencies. You have to excuse me, I've got a bit of a cold. And we managed to, we were lucky to get 2 years to explore that in quite a bit of detail. So we were part of a European initiative called ECO, and our responsibility was for a work stream called Integration of Services. And so we managed to spend 2 years really with a lot of time talking to people, particularly talking to NHS colleagues, social work colleagues, people who were also involved in community development and employability, and really looking at, you know, if we're going to break down the silos, we probably need to think about, you know, what would a role look like that worked in a more holistic way, rather than working from a kind of, as John's been talking about, a kind of specialist fix-it kind of model. And so in 2006, we created a role that originally we called Health Case Manager, and we now call it Wellbeing Coordinator, because I think that's a bit more friendly. Health Case Manager sounds a wee bit sort of formal. And we also spent a couple of years looking at how would a health case manager or a wellbeing coordinator, what would they do? What would be the different way that they would work if they were in the middle of the silos? And we were very fortunate to get to work with the College of Holistic Medicine in Glasgow, who were an organisation of holistic practitioners, and they worked with us to create what we now call the holistic assessment, or the holistic conversation, which you saw a demo of yesterday. And that was loosely based, structurally, it was loosely based on an occupational therapy assessment, which was called the Canadian Occupational Performance Measure, which you probably, judging by your wee smile, Caroline, you've maybe come across it before. But what we did was we took the headings from the COPM, as it's called, the Canadian Occupational Performance Measure, and we developed a kind of methodology around how could we make that much more conversational, and how could we make it a wee bit softer, I would say, than the way it was being delivered when we saw it at first. And so we started to test that in 2008, the holistic assessment and case management way of working. And now we've probably had well over 1,000 people who've been supported in that way. So when John was giving you the vignette of Tony yesterday, we've probably got well over 1,000 Tonys and Angelas and various different people that we can draw on quite a body of evidence now of what happens when we begin to work that way. We've had 2 formal evaluations. So our first formal evaluation of that as a methodology was in 2013. And we had a public health consultant, a Dr. Janine Thulis. She spent quite a few months actually with our Edinburgh team looking at the holistic assessment case management methodology and what difference that made to people. And so you can download that evaluation from the Community Renewal website, again under the resources section. And more recently, we had a team of 13 link workers in GP practice. Sorry, we had a team of link workers in 13 GP practices in Moray. So we covered the whole of Moray, and we trained them all in this methodology. And there's an evaluation from 2018, which looks at the kind of outcomes from that. So if you're interested in the kind of evidence stuff, you'll be able to download that from the Community Renewal website. So I thought, after giving that sort of brief introduction, I would just open up the workshop. I don't want to do any more death by PowerPoint, although there's one case study that I might use depending on how the conversation goes. But I thought we've got half an hour, and I thought it might be better actually if we just have a blether for a half an hour and just chew the fat with each other and see what sort of conversation that we can get going around it. Caroline, you've got your hand up. Do you want to kick us off?
Yeah. On listening to the workshop yesterday and today, because I'm in NHS Borders, I was sent along to MAP training about 3 years ago, which is very similar in the way that it looks at the whole person and looks at where they want to begin and where they want to sort of start, what their priorities are. So I'm thinking that it's not dissimilar to MAP. They almost run along in alignment. But I guess we use MAP as, we call it a behaviour change, but really it's a bit about looking at the whole person. And certainly the whole systems approach work that's been done down in IMouth is much more reflective of looking at the whole place. So we're just starting the placemaking discussions in the town that I live in. Hawick is one of the towns that's being taken forward with some Borderlands funding. So we're just at the beginning of a journey of getting all the partners to sort of align or be on the same page or be on different pages but talk to each other.
Yeah, no, that's great. Yeah, I don't know a lot about MAP and to be able to compare and contrast it, but it's useful to know that we're basically coming from a similar sort of maybe set of principles there.
Yeah.
One of the key principles that we were very deliberate about at the beginning was, John touched on it this morning, was around power balance. And I think Community Renewal as a community development kind of philosophy organisation, we're always very interested up front about power balance. So we've tried to create a methodology that from the beginning shows the person that we're in this together. This is a partnership, and we might need to put a little bit more in to the partnership at the beginning because they may be might be a wee bit shy, or they might be a bit underconfident, so we might need to put a wee bit more in at the beginning. But we're definitely looking to see the emerging authority of the person, and we created the methodology that you saw yesterday has a whole set of follow-on processes where we quite actively look to see, can we capture any evidence that their agency and their authority is beginning to come into balance. So you've got your hand up, Colin. Did you want to kick off a conversation?
Yeah, no, I was just going to say, actually, I did a few months ago, I did a coaching program.
What was it?
A coaching program, for coaching. And actually the approach was almost exactly the same as the interview approach you did yesterday in terms of, eliciting information from the person, and getting them to see, you know, what the issues are, where they'd like to be, and how they'd like to get there, as opposed to saying, actually, oh, you've got this issue, right? How are we going to sort it? You know, so that I found actually quite interesting, and I think obviously a lot of this whole person approach, you know, sometimes you do it intuitively in terms of your everyday working with people, and sometimes you think, oh yeah, I do that anyway, and sometimes you think, oh, actually, I think we have a tendency to jump in and offer a solution that we think might be suitable, rather than a solution that's going to, you know, it may end up as the same solution, but it's come from the person. And you know, I think one of the things I've picked up over the yesterday and today is that obviously this takes the person-centered approach always takes a lot of time, and I suppose that's something that public bodies and staff don't really have much of. So I suppose it's how do we balance out this, you know, approach of time versus providing a quality service, or a quality, I suppose a quality service to the person we're dealing with.
I think that's a great point, Colin. One of the things I think is different about working in this way, and I think you're right, it's a much more intuitive way to work than trying to funnel people into different services. Our principle in community renewal from the start has always been, deep down, we believe that people know what they really want. And you know, we've tested that principle now with 40,000 door-to-door conversations to see what the community want. And we've tested it with well over 1,000 one-to-one situations in a kind of case management scenario, and it really holds true for us. So it's moved from being a philosophy and a principle to really having good evidence behind it, that deep down they know much better what they really want than we could ever know. And so that's quite a good guiding principle. We had an experience a few years ago where we were invited into NHS Grampian, actually, and to try and put our principles into a very, very, very time-bound scenario. And that was with 6 GP practices in Grampian. And as you know, normally GP practices are inundated with people. They don't have enough appointment times. Generally an appointment will last about 10 minutes, and you know, it's trying to quickly get some clinical symptoms from the person so that they can either decide to write a prescription or send them off to acute for a consultation. So we had an interesting experiment with NHS where we were saying, look, let's see if we can make a change to your appointment times. And one of the GP practices went along with it. So only one. We're working with 6. 5 said, oh, we couldn't possibly do that. Yeah. But one of them went along with it. And so the appointment time changed from a 10-minute appointment routinely to a 15-minute appointment routinely. At the same time, they were bringing in telephone triage and things like that, which meant that they were able to start dealing with a lot of folks that would have ended up coming for a GP appointment. They were actually able to deal with it on the phone because it was maybe a repeat prescription or whatever, which meant that they were able to do these 15-minute appointments. And what we said to them is, if you could, and double appointments in a GP setting are quite routine, you know, so you probably noticed that yourself if you've got to go to the GP for maybe the results of tests and things like that, then quite often they'll book you in for a double appointment, which would be 20 minutes. But we managed in one GP practice to make that 30 minutes, and 30 minutes was enough for them to do the holistic assessment. And it took us 18 months to persuade the GP practice to do the training. And I would say on the first half day of the training, the penny started to drop for the GPs, because what they were getting was a whole different view of a person than they'd ever managed to get before. And as you saw yesterday, I don't know if they deliberately said, well, you have to demonstrate this in 30 minutes, but you saw that within a 30-minute conversation, you can get a lot of information about a person's situation. And you may have come across this term realistic medicine, which is, it was Dr. Catherine Calderwood, who unfortunately was the chief medical officer until she had an issue with going to a holiday home during COVID, and she lost her job. But I thought she was a very good chief medical officer, and the paper that she wrote on realistic medicine, I thought was absolutely fantastic. And basically what she was saying is, we need to get away from a prescribing culture in primary care and move to, a culture of trying to deal with issues in a non-prescribing way. But it's very difficult, I think, for GP practices to make that transition, because there's nothing else in place that's going to replace the prescribing culture, and people want a result when they go to the GP practice. So we started to experiment with this half-hour conversation, and we had really quite fantastic conversations begin to happen between GPs and their patients, which really got to the root cause of some of the issues around mental health and depression. So in the past, it would have been much more, you turn up, you end up maybe with antidepressants after 10 minutes, and you're feeling quite good because you're hoping to get antidepressants. So you go home, you start taking your pills. And of course, years ago, we thought antidepressants weren't addictive, but now we know that they're very, very difficult to come off. So we started to see GPs having very different conversations with their patients, really getting to know them, getting to know their family situation, getting to know their housing situation, and coming up with co-designed solutions that weren't relying on prescriptions. And it's like what we're trying to do at the moment is quite experimental, and the work that we're doing in Grampian was quite experimental. So I'm not, unfortunately, able to say, oh, now this is the way we do primary care, and this has been rolled out across the country. I wish that was true, but there was good, very, very good evidence started to come out. Again, if you're interested in that, I sound like a salesman now. I don't even work for Community Renewal anymore, but there's a good report on that on the Community Renewal website. It's called Modernising Primary Care, Deep Community Engagement, and it goes into a bit more detail on disentangling the medical and non-medical issues. I think it's a good point, Colin, that normally that's one of the first things that people will say, oh, we couldn't possibly do that because it'd be far too time consuming. But of course, if you look at, and if I've got time, in a minute, I might show you a typical 18-month case study for us. And it would be very difficult, I think, to point to any other way of working where you would see that amount of progress in 18 months. But making a commitment to people for 18 months is usually quite a difficult thing, because a lot of funding wouldn't allow you to work with one person for 18 months. So any more points that anyone wants to chip in? My colleague Ray, who's the actual Neighbourhood Transformation Team Manager in Bingham, I think has just joined the call. If you put your camera on, Ray, and say hello. Yep, Caroline, you've got your hand up again.
Hi there. I was just going to say, I like the door-to-door principle and the descriptive factors that you gave about people being like a bit more chilled in how they're dressed, maybe not having their lanyard biting, being the first thing that people see, and using that kind of how you doing type approach. That was really good to see and hear. And also, I'm aware that some work we've done with ChangeWorks, we've looked at SDI codes in targeted areas. So that would be really helpful for us to think about when we're engaging with some of our elderly clients.
Yeah. What's an SDI code?
Oh, the SDM code, the postcodes thing.
Oh, right, the postcodes.
The Scottish, is it
okay.
Scottish?
Yeah, the SIND.
That's it. Yeah, sorry. It's just I'm not very clever.
No, it's just I hadn't come across SDI codes and I was intrigued. So yeah, so you've used postcodes to do specific targeting, right? Yeah. No, great. I mean, years ago, it hasn't kind of come through so much in the last couple of days, but we did a lot of work in anticipatory care between 2008 and 2014, where it was very much targeted at SIND areas for cardiovascular screening programs, where there was very low uptake coming from certain postcodes, and we worked very closely with the GP practice to use their data sets to identify who you're really struggling to get a hold of. And we then took 6 nurses on secondment, and we trained them up in community development principles, and they then went back into the NHS and worked that way for quite a few years. So it really works, you know, that kind of target, especially if you're already inside the NHS and you can get access to the data. You know, we had to go through a lot of loops as being an external agency to get the data. Miriam, you want to come into the conversation?
Yeah, the door-to-door and the reaching out to people, it reminded me of a project that we did before the pandemic with a primary school. We started with a primary school, and they wanted to increase their parental engagement because they said they always had the same parents coming in the door to answer all the surveys for their kids. And one of the things that we did is, okay, we have a lot of volunteers and we know where the parents are, which is during the pickup times. So what we did is literally every week approach them with a question about them and about the school. So like, oh, do you remember a story about your teacher when you were young? And then we would ask them, oh, what do you think about the teachers at this school? And it increased, the parental engagement increased to almost double of what it was before. And it was just having, like, let's just go and see how it goes. We are not forcing anyone to answer, but instead of them coming to an event, it was us going to them. And yeah, it reminded me of that.
Yeah. Would it be helpful if I talk through a case example of how the holistic assessment goes into case management? Would that be helpful? Yeah, it's a couple of nods.
Yeah.
I'll just share my screen just now. Try to do that. Can you see that okay? Can you see the screen? Give me a thumbs up if you can. Yeah. Okay.
Yeah.
So this is a case example of a lady who is just on the outskirts of our Bingham project. I'm going to run through it reasonably quickly so that we can still have sort of 5 minutes of conversation around it. But we met this lady doing door-to-door work, and it's very unlikely that we would have met her if we hadn't knocked on her door. And through that initial listening conversation, we found someone who quite clearly needed a bit of support, but she wasn't coming forward and she wasn't asking any agencies for support, and she'd been kind of stuck in her situation for a while. And when we found her, what we found was someone who'd been in an abusive relationship for a long time, which had led, you know, to having panic attacks and not wanting to leave the house and feeling agoraphobic and, you know, a lot of anxiety and quite low mood. And she'd lost her confidence because she wasn't going out, and, you know, this had really knocked her confidence and her self-esteem. She didn't have very good kind of self-worth. She'd also lost contact with her friends, and so she wasn't really in any sort of social situations. She was very, very isolated. Pretty much every day was the same. She didn't have much of a structure to her day. She didn't really leave the house very much. And despite the fact that she hadn't worked for years, she had some quite significant benefit issues around the type of benefit that she was getting, and she also had some debt issues. So when we did the holistic assessment with Angela, the first thing that she mentioned, or not so much the first thing, but the thing that was most important for her to change in her life was to get a divorce. She was a bit stuck in her situation because her ex-husband had moved to England, and she was finding it difficult to actually, get the proper advice towards getting a divorce. And that was the thing that was her highest priority, because that was the thing that she felt was holding her back. And after that, she talked about her mental health. That was her sort of next highest priority, that she wanted to really, I suppose, heal from the kind of trauma that she'd experienced, and get back to the way she used to be, or get back to a new way of being. She was keen to develop a bit of a daily routine, and start to make some new friends and get into that. She scored that 8 out of 10. And then, looking more towards the future, because this is a very future-orientated conversation, she thought she might want to take up volunteering opportunities, and maybe, way in the future, get into work. And so she was quite a complex set of needs, in a sense. And so this is the picture of what the case manager, who was called Ursula, this was the picture of what Ursula did with, Angela's not her real name, but let's call her Angela. So one of the first things that we tackled with Angela was her benefits issue. She was on job seekers allowance, and she shouldn't really have been on job seekers allowance, because there was absolutely no chance that she was going to be able to go into work at that point. So we started the process of appeal to try and get her shifted from job seekers allowance to employment support allowance. We also tried getting her some counselling from a local organisation called Health in Mind, but that didn't quite work out for her, and both she and the counsellor felt that they weren't really making progress. So she came back to us, and we then introduced her to a specialist trauma counsellor in Women's Aid, and that person was the right person for her to get support from. We engaged a solicitor for her, both in Scotland and in England, so she could start the process of getting the divorce. And she also had a knee problem, so we ended up getting her physiotherapy to try and sort out her knee problem, which was affecting her ability to walk and was affecting her ability to get out and about. And alongside the knee problem, we organised for her to get a free gym membership at a local gym as part of an organisation called the Thistle Foundation. And towards the end of the year, she started doing some voluntary work in a shop in Portobello. And that was achieved through Volunteer Centre Edinburgh. So you can see quite a complex picture, but the main contact was Ursula. Ursula was in the middle, and Ursula would introduce her to an organisation, she would come back to Ursula. She would introduce her to another organisation, she would come back to Ursula. So Ursula was her constant. But the amount of time Ursula was spending with her was dependent on how much input she was getting from other organisations. And then this is the second year. We won the appeal, so we got her shifted from employment support onto job seekers allowance. But actually, although we'd managed to get her into a space where she was getting breathing space and she wasn't getting so much hassle from the job centre, she actually got a part-time job during that year. So kind of like almost the emotional safety net of helping her go into employment support allowance shifted her mindset a bit, and we got her a part-time job. And she also did some training with fourth sector training. She continued to go to the gym a few times a week, and she started to volunteer with a time bank. And by the end of that year, she was actually employed 21 hours a week. So she was really beginning to come off the need for benefits, and she was looking for a second job. And so this was someone who hadn't really left home for 20 years, and 18 months later, this is the situation that they were in. And like Tony in John's example yesterday, Angela is not an outlier of a case study. She's not a rarity. This is what we expect to happen when we work that way. And we constantly evaluate with people, how do you feel this is going? And so after 18 months, she felt that in terms of her mental health, she was 80% of where she wanted to be. In terms of her routine, she was 90% of where she wanted to be. She got her divorce, and so that was 100% success there. And in terms of volunteering and employment, she also achieved that, so that was 100% success. And what we've realized over many, many years is that when we work this way, that's what we expect. So we're not sort of going into a relationship thinking we'll expect to see a little bit of change. When we work this way and we make that commitment to someone, we expect to see really quite transformational change. And the important thing about the change as well is it's sustained. So with Angela, with Tony, there's no it's not so much snakes and ladders as maybe when we work in a more fragmented way. You know, it's very much a kind of game of snakes and ladders for a lot of people. They make a bit of support, make a bit of progress, and then they slide back. So I don't know if it was that useful to see that's quite a typical, what we would maybe say more complex case, but we have a lot of them in the neighbourhoods that we're working in. We've got 3 minutes left, so I don't know if you want to make any comments or chip in on what you saw there, Caroline.
Hi, I hate to sound like an NHS worker, but who pays for the physiotherapy and things like that for Angela?
Well,
does that come out of your budget, or does it come from?
That was NHS physio, yeah.
Yeah, so you made the referral through NHS to get it, right? Okay.
Through the GP practice into.
That's fine. Right. Okay. I didn't. Yeah.
No.
And
this is all about using the existing resources.
Yeah. And I like the way you sort of almost presented it like a mind map type theory, you know, of looking at Angela, looking at the whole person, having all the different signifiers, and then showing progress. Thank you.
Yeah. Miriam, do you want to come in, and then Colin?
Yeah, no, I really enjoyed it. It reminds me of our wellbeing and digital coordinators. We want to support people digitally, but we can't do that without really understanding the wellbeing of the person and their interest, or how we can support them. And I really like the partnership that we actually have with Community Renewal in terms of then taking them to the next step, which is the employability and everything else. So I can really see the whole holistic assessment and support.
And the last word is going to you, Colin, because I think the Zoom will switch off.
Oh, right. Okay. Well, that was very useful. Thank you very much. I was going to ask a question about, I suppose, more evaluation. But is there any? Are you looking at any sort of evaluation in terms of cost savings as a regard to this type of approach? I mean, because obviously, I mean, we've talked about commissioning, and we've talked about that side of things, and we've talked about getting rid of outputs and targets. But obviously, at the end of the day, the public sector, it's all about, you know, costs and procurement and things like that. Has it been demonstrated in terms of a saving? So, you know, for example, if this approach hadn't been taken to help this person over 2 years, this person might have cost X amount over another 20 years, type thing. Yeah. Is that type of thing built in or not?
I think it's probably more built into the Lifting Neighbourhoods Together. So there's 2 evaluations that you can download that are on the Community Renewal website that just talk about holistic assessment and case management. We didn't have it to do the cost benefit analysis is quite a big evaluation, and we didn't have the resources. But within Lifting Neighbourhoods Together, there's more of a cost benefit analysis built into that. what a really interesting thing, if you haven't seen it already, Colin, is called the locality report, which is locality diseconomies of scale.
Yeah.
It looks at 4 case studies. That's the sort of reverse of what we're doing here. So it looks at what happens when you don't have a holistic intervention. And they give 4 case studies and show the cost to the public purse of not working in that way. But it's quite difficult to actually, you know, it's not an easy task to try and work out how much would it have cost in the public purse. We've got a lot of anecdotal stuff, particularly around when we've worked with children in families where there was a danger of the children being taken into care, stabilise the situation. And so we're able to look at that because it's quite a concrete cost. Or if we've supported young offenders not to go back into jail, it's quite easy to look at that because there's a concrete cost to going back into jail. But with this more kind of multifaceted approach, it's quite difficult to predict how much is actually being saved. So I think the cost benefit analysis of lifting neighbourhoods together is more for the project as a whole rather than for individual cases. I'm
thinking just for the individual case there, I mean, you know, moving people from one benefit to another that's more suitable to then a job in such a short space of time is actually, you know, even in itself is actually quite a demonstration that using this approach is actually not only better for the person mentally, but it's also better for, you know, because obviously, like I say, it's not the ultimate achievement is not to reduce costs of services. It's actually to get the person to a better place. And if that has a side effect, then that's great. It might cost more initially, but actually in the long term, and I think that's quite difficult to get across when we're doing these types of renewal projects. You know, like projects that are funded by the lottery, you know, we have to show legacy and management and maintenance and all this sort of stuff. And it's about finding the evidence to say, well, actually, yes, there might be a small cost saving, but that's irrelevant because that's not what we're trying to do.
So what the presentation that we saw earlier on gives you the evaluation framework for lifting neighbourhoods together, and there's a microsite called liftingneighbourhoodstogether.org, and the baseline evaluation you can download from that, and that will give you what Lifting Neighbourhoods Together is trying to measure. But one thing that didn't come up so much in the last couple of days is part of the reason. So the Lifting Neighbourhoods Together concept was really come out of my own experience and thinking over 20 years. It started in 2012 when we started to see chunks of SIMD areas come out. So we saw chunks of neighbourhoods coming out of the SIMD 15%. We actually saw 5 data zones come out of the SIMD 15%. And we were able to track that back to reduction in income deprivation and reduction in employment deprivation. So we saw that at a kind of neighbourhood level, when you were hitting about 10% of the population going into work, you were starting to see real radical change. Unfortunately, when we went back in 2016, they had slipped back into the SIMD 15%. And John was alluding to that yesterday, because what happens is people move to the next best area. If you're not doing the community development work and you're not making the community a better place to live and people taking more pride in it, they'll just get a job and move away, and you're kind of back to the start. So, but it's a fascinating topic, looking at the kind of evaluation of it. As I say, you can download the stuff that Ian was talking about. You can download the baseline and all the things that they're going to try and measure. Obviously, COVID has made it difficult because there's been 2 years. The project's 2 years behind because of COVID. So it's really only in the last 12 months that it started to get operational again. But certainly the things that we thought were measurable, they're all laid out quite nice. We've just been given a signal that we need to bring it to a close.